On to the Kingston CCG governing body meeting being held in public. It's the 41st one of the meetings that we've done. Just for a quick round of introductions of who is here on the board. So my name's Naz Giovanni, I'm a GP in New Malden and also the CCG chair.
Sarah Blow, accountable officer.
James Murray, Chief Financial Officer.
Gareth Hull, GP board member.
Catherine Yates, nurse member.
Annette Parts, GP member.
Atin Gold, Chair of the Council of Members.
And Iona Liddington, Director of Public Health with the Council.
Yeleni Roberts, Director of Finance at Kingston and Richmond CCGs.
Vicky Harvey-Piper, Director of Corporate Affairs for Kingston and Richmond CCGs.
Fergus Keegan, Local Director of Quality for Kingston and Richmond CCGs.
Julia Travers, Local Director of Commissioning for Kingston and Richmond CCGs.
Liz Mooabo, Kingston Health Watch.
Naim Iqbal, GP board member.
Jim Smiley, lay member.
David Knowles, Vice Chair, and from the front page of the agenda sheet you might be relieved to know that the Chairman is here and that I'm not chairing the meeting.
Tonya Michaelides, Managing Director.
Jo Dandridge, Governance and Business Lead.
Okay, thank you. And we've got apologies from Phil Moore and also Pete Smith, who are unable to attend today. Before we go on to the script that we have to do, are there any matters arising to conflict of interest which are pertaining to items on the agenda that people have not declared previously? No? Okay, so first of all, welcome to the governing body meeting in public. In relation to questions from members of the public, the CCG is committed to openness and transparency and therefore wishes to conduct as much of its business as possible in a session that the public can attend and observe. Although the meeting is held in public, it is not a public meeting. This means that there is no opportunity for the public to ask questions apart from that offered at the chair's discretion. There is a specific slot at the end of the agenda for any questions relating to items not on the agenda. The governing body meeting is also being video recorded as part of the commitment to make information as accessible as possible, and the video will be put onto the website within a few days of the meeting. The CCG does not allow any other recording of the governing body unless agreed by the chair prior to the meeting. The CCG has a protocol setting out how it will conduct its meetings, and this is available on the CCG website. So if we can come to the minutes of the meeting back in November. As regards matters of accuracy, can we just go down page by page? So page 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay, so if we can sign those out off as an accurate record. We've got a couple of actions and matters arising. So the email to GP practices to find out what level of difficulties experienced with supplies of flu vaccine. Fergus?
Very little to update, very little feedback actually. I think probably the biggest feedback we had was a slight irritation that people were being asked for next year's vaccination plans whilst we were still in the process of this one. But still very happy if individual practices are experiencing difficulties or challenges that we can provide some support with mutual aid from other practices with vaccine supplies. So not much more to update than that, sir.
Great, thank you, Fergus. And the deep dive into dementia diagnosis rates to be presented to the governing body, and that's actually on the agenda proper. Okay, so if we can come to any questions from members of the public pertaining to items on the agenda. No? Okay, so can we just go, we'll go to the items that were taken in private in November. So there were 4 items regarding the part 2 in November. One was talking about the South West London System finance position. And also, second one was around the review of lay member remuneration in the South West London Alliance CCGs. CQC send inspection and outcomes and the next steps, and there is going to be a presentation today on the send. and also the options appraisal of closure of supported living provision at Mill Place in Kingston. Okay, so if we can come to the Accountable Officer's report. Sarah?
Yep. So firstly, Happy New Year to everyone. And we have a present for the new year. It is the new long-term plan for the NHS, which was published yesterday lunchtime. I thought it was worth just saying a few words about the long-term plan that's been published. It's not, so it did only come out yesterday lunchtime, as I said, which means that I have read all of it, but I doubt anybody else has. But it has got some priorities that I think we already knew about. So there is a real focus there on prevention and keeping people healthy. There's a real focus on community, primary care and mental health, which we also expected. The primary care part of that is about how general practice works in networks, and that there will be additional funding that will come down to primary care for that, and also around the community and supporting people in a different way around those networks. There will be additional funding for that. We are looking, as you know, at children, young people, mental health across South West London, and that's another one of the priorities that's in the plan, as well as looking at investing more in mental health services generally. The plan, I mean, I would suggest people do go and read it. It's 130-something pages or 120-something pages, but it is worth reading. It's twice the size of, I think, of the previous plan, but it's for 10 years instead of 5, so that would be to be expected, wouldn't it? There will be further guidance that we will receive about what this actually means, because what this plan does is it gives us a high level, actually there is some detail in there, but a high level idea of what the priorities are. What it doesn't do is give us all the detailed information about how much money we're going to get and how we have to use that money. And that will come out, we were hoping today, but I haven't seen it yet today, which means that it may not have arrived. But we are hoping that that will come out either today or at least this week. And then we will have some further information that we'll be able to share with the governing body. We will analyse this because it has only just come out, but we will analyse this as a team, and we will bring back a further discussion to the governing body about the detail of the plan, and also once we get the planning guidance, the detailed information about the money we have, how we have to use that going forwards. But we are going to be talking about it later. Local health and care plans will be part of a South West London plan, which we will have to have for autumn this year. So it's really important that we get our local plans right, because it will feed into our South West London plan, which as part of the new 10-year plans, we will have to submit nationally. So that's coming shortly to us. Is that okay?
Thank you. Any comments or questions for Sarah? Yes, sir.
Don't test me, because I don't remember all of it.
Rob.
Yes, so there is more money. The NHS was promised more money overall, and there is more money coming down into the system. That they have said that will go. Some of that funding will go to primary care as part of primary care networks. So GP practice working around 30 to 50,000 population. We haven't seen the detail of that yet, so we've got a very high level piece of information here that says that there will be more money attached to that at a national level. There will be more money, as we know, for children, young people, mental health, and we are trailblazers in South West London in Sutton, Merton and Wandsworth, and hope to be second phase in Kingston, Richmond and Croydon for that money that will be coming down. And we have yet to see the detail of that. So we know there's more money, and we know it's going into some of those areas. We haven't actually had the allocations yet for individual CCGs or seen the national guidance around what the detail of what will be required from, say, primary care in order to get that finance.
But I'm not sure whether it be, if say we've got a new way of doing things, and then go and apply for the money for that, or is it just going to be an equal split amongst all the...
I don't know. I don't know at the moment. I would think, to be honest, that it won't just be an equal split. It will be an offer which practices would then have to take up in order to get the money. Yeah. So the way I have read it, it is that it's a new contractual arrangement which practices would then have to choose to take, and then they would then get that funding to do that piece of work. but I don't have all of the detail. That will come, I'm sure, in time.
I also gather that the funding is actually allocated to making sure that they work within community and MDT
yes,
networks.
It is.
Right.
It's all around community, mental health, primary care, working together, yeah.
Okay, any other comments or questions? Yes, Liz.
I just wondered whether there's a rough time scale for that second tranche of funding on the children and young people's work that the other part of South West London has got, when we might get some in Kingston.
Yeah, so it might be worth just saying that there are two things that are happening in South West London. One is we have a model of care for children and young people which we have agreed across South West London and we are funding. And that supports hubs of schools in each borough working with a specialist advisor who will support the schools, and we've got a number of things that we support them with, such as advice, such as apps, such as some referral options in local schools. The national funding is very specific and supports a much bigger team of psychotherapists, psychiatrists, workers working with schools and families at a local level. So we are rolling that out into the 3 boroughs that received that funding. We are hoping that going into next year they will make another announcement. So when I say next year, I mean next financial year. So sometime after the 1st of April, I'm hoping that they will make another national announcement to say that there's further funding coming forwards, and we would then apply for second wave, and I think that we're in a good place to do that. But there is still work going on in Kingston around children and young people mental health that we have agreed to do locally based on a South West London model.
Great, thank you. Any other comments or questions? No? Okay, thank you, Sarah. Tonya, can we come to the MD's report, please?
Sorry, a few things to report this time. Winter communications and engagement campaign. Just to say, actually, today, and we are touching lots of wood. We've managed well across the winter period. We've managed our flow. Performance obviously is still not 95%, but it's holding around the 90%. So, and generally, the partners across the system, and Fergus will give a further update in his item, but generally, the system appears to be holding up, and we're not having significant challenges above and beyond the normal winter challenge that you would get. So I think that's a real credit to the system working that we have in place in Kingston now. And I'd like to thank everyone who's worked so hard over the winter and Christmas periods to make that happen. But we have obviously got a significant winter communications and engagement campaign in place. So across South West London, we continue to work with health and care partners to deliver a targeted winter communications and engagement campaign. The campaign has been discussed at both South West London Urgent Care Transformation Board and the Kingston and Richmond A&E Delivery Board. And we also run a CCG internal session with staff to recruit them to be winter champions, to go out and talk to the public and share the winter messages that are being developed both locally and nationally. And we're encouraging all our staff to take that opportunity up. And all members of the SMT will be doing that piece of work as well. And I've offered anyone who wants to come with me when I do mine, please join me. Throughout winter, we are also promoting the national NHS 111 campaign, which seeks to drive understanding of the role of NHS 111 and to increase the number of people calling NHS 111 when they have an urgent but non-life-threatening medical need. The national campaign focuses on those groups who are particularly high users of A&E, namely parents of children 0 to 4 and young adults 20 to 29. And in December, we launched phase 2 of the national winter campaign, which focuses on promoting community pharmacies and reminding people about the 8 to 8 extended access GP service and how to access it. The impact of this year's campaign will be measured against the work we did in South West London last year, and we will look at the impact of the campaign materials on indicators such as attendance at ED departments and flu vaccination figures. Moving on to Brexit, we received a letter in December asking CCGs to identify a board-level lead to undertake an assessment of risks associated with the EU exit and to do the risk assessment by the end of January 2019. For South West London CCGs, because we're so similar, Jonathan Bates, who is the Director of Commissioning Operations for South West London Alliance, will take the lead on behalf of the CCGs. So there is a request to undertake a risk assessment in areas such as supply of medicines and vaccinations, supply of medical devices, and we're working together across the Alliance to complete that risk assessment. We continue to develop both our governing body and our team members locally. So for commissioning team, we've run a number of staff learning and development sessions focused on areas of importance to refresh their knowledge. So we've run sessions on public health, performance and information and public and patient engagement. And the governing body also had a session on public and patient engagement. And I'd like to thank governing body members for their attendance at that development session recently. I'd like to congratulate Kingston Hospital on their award for staff retention and wellbeing. Kingston Hospital has been named as our Health Heroes winner in the Staff Retention and Wellbeing and Employer of the Year category, which was organised by Skills for Health. So I'd like to congratulate Kingston Hospital for achieving that award. And just to finish, and Iona's there, she might want to add some to this. Connected Kingston. The soft launch of Connected Kingston took place in September 2018, and that's our social prescribing digital tool. And the tool supports the training of frontline staff from a range of partners, including health, social care, the voluntary sector, Job Centre Plus and housing, and it in strength-based conversations and empowered signposting. So we've had included GP practices within that training. The full launch, including encouraging residents to self-refer, is on track to roll out from the middle of January 2019, with a gradual build-up supported by a partnership communications campaign to the end of March, culminating on the National Social Prescribing Day, which for your diary is the 14th of March 2019. And then we will do an evaluation of the work done to date and bring a full report next time to the governing body in March. So that's all I had to report this time, Chair, but happy to take any questions.
Great, thank you, Tonya. Okay, any comments or questions for Tonya on the MD's report? No? Okay, thank you, Tonya. So if we can come to the dementia deep dive. Julia, is that for you?
So I'd like to introduce Dr. Narida Burney, who's one of our local GPs here in Kingston, who is our champion and lead for dementia within the CCG, and she's going to run us through the information with regards to the requirement of the CCG to be demonstrating delivery against the dementia target and the actions that we are undertaking and continuing to undertake to deliver and work towards the achievement of that very, very challenging target. Thank you.
Thank you. Apologies for my voice, but hopefully you can hear enough. If you look in your packs, you've got the slides, and I think I'll just talk through those if that's the easiest way for us to look at it. So for the first slide, which is looking at the performance map to actions, for those of you who haven't been spending the last couple of years of your life looking at dementia diagnosis rates, I might just explain briefly what they are. If we think about the prevalence in the population of how many people we think should have dementia, so for the Kingston population, that's a certain number. And then we know the certain number of people in Kingston who have already received a diagnosis of dementia. If we put those two figures together, we get a percentage. The ambition is that we should reach a rate of two-thirds, 66.7%. As you'll see on that graph, following what's happened over the last 3 years since 2015, we've not yet achieved 66.7%. Various things have happened along the way in that pathway to make it have such a variation, and probably the key things to point out for you are when we first started working to clean up coding, because obviously the way that these figures are found are by what diagnosis is coded on the GP notes. So we went through and did an exercise to do that, which brought us a little bit of a peak. We've continued to do that work. The other significant change that happened was in April 2017 or March 2017 when the denominator changed. Basically, NHS England changed how they calculated the denominator of this figure. It went from people living in the borough to people registered with a GP in the borough. And as you can see, unfortunately, that gave us an adverse change to our figures. So there we are, we're sitting at just on 62% roughly. So if you look at the next slide, just to answer some of the obvious questions that people have raised in various times, do we think that the prevalence is wrong for Kingston? Because we're all finding it quite surprising that we've not been able to achieve this ambition. Well, if we look at this, it doesn't really appear that Kingston is an outlier in prevalence. I've met with Helen Raisin as well with Public Health, and she's again looked at it for us. We really feel we've put to bed this thought that Kingston has got an outlier of their prevalence. We really do think it seems to be true that we've got the right numbers and the right ambition level of prevalence that we're looking at. If you look at the next slide, another query that's often come up as to why maybe we're not achieving the ambition has been that is it that we don't have as many care home beds in the borough. Obviously, if you think we would expect a larger number of people with dementia to live in a care home environment just because of the level of need that they may have from that condition. And as you can see, really we don't think there's a big difference there. Really, we are comparable to Wandsworth and Sutton, who are achieving the ambition. So we don't really think that is where the answer lies either. So I guess that comes on to working out where are these people that we're not yet diagnosing, and what can we do about trying to find it. So on the next slide, I'm summarising what we've done so far, and I'll go into a little bit more detail. But to put numbers onto this roughly, we would expect that if we do have 66.7% of people diagnosed, that's around 1,150 people in the borough diagnosed with dementia, and that would be the aim of we would have achieved the ambition. We're short of that by about 80 patients. So we're not talking large numbers. It's around about 80 patients is what we're looking for that would get us to the target. So under the regular support and review from the Dementia Clinical Network, NHS England coming and visiting and meeting with myself and with Rachel Rowan as the Mental Health Commissioner, these are some of the things that we've been doing. We've employed someone we're calling a memory nurse. So Kathy is a experienced old age psychiatry nurse who has come on secondment to work with us to try and help with case finding. So she comes round and visits each of the surgeries, asking for people who have worries about their memory to be reviewed, and then she will assess them and help enable a referral through to the memory clinic if that's appropriate. She's also following up patients who've been identified while they've been an inpatient in hospital that may have memory issues, and so then she's following them up when they get back to the GP practice. So just to give you a snapshot of that, we did an audit for the patients in July last year who were identified by the hospital while they were inpatients as possibly having memory issues. That was 17 patients that were discharged back to primary care with this query raised. Out of those, when we looked in about November, 4 had died. 1 of them had moved out of borough. 7 of those had been referred to the memory assessment service, so 7 out of the 17. 4 had declined referral and didn't want to follow up with the memory assessment service. And 1 had been found in this audit to have not been recognised by the GP, and so is now in a position to be offered referral. So I think that gives us an indication that these patients are being looked at, but for various reasons it's not always turning into a diagnosis of dementia. Other actions that we continue to do is the coding review of practices, which is done on a regular basis with Sarah coming around to each practice, searching for any patients who may have been missed on coding. So people who've been either newly diagnosed at the memory service and haven't yet been coded. So she's doing that on a regular basis. Kathy and I, the memory nurse Kathy and I, have gone round to visit with each of the practices to really put together an action plan for each practice of where some of their missing patients might be, and to give them support and encouragement on some of the things that they might not have thought about. That would include things like doing care home assessments and making sure that patients new to the practice who've moved into a care home in their area, make sure they've been reviewed and a diagnosis considered. Patients with MCI, mild cognitive impairment, to make sure that they're being reviewed regularly, because patients with mild cognitive impairment have a higher incidence of turning into someone with dementia. We've also thought about anybody who's at risk, so patients with Parkinson's, patients with diabetes and other vascular risk factors. And we've also highlighted that there may be patients who are over the age of 65 that just haven't been in contact with the GP for more than 18 months. And there's a question about why that might be, and they're probably another group that needs to be considered whether they should be looked at. The other actions we've done is to recognise that close working with the memory assessment service is very useful. So I meet with them and have done several times. We've helped them look at their waiting times and if there's any work that needs to be addressed with that. We've looked at whether or not there's any problems still with imaging and delays in getting CT scans done during the diagnosis process. And so we've helped them work through that, as have the NHS England team. I've also met with the hospital consultant, some of the hospital consultants, to look at whether there's any other close working we can work through primary and secondary care together, because obviously the hospital do have a strong dementia strategy, and we'd like to work together with them if there's any joint working that would be useful. And probably the main thing that's come out of that is helping us to make sure we're getting the right list of patients that have been identified in the hospital as inpatients at risk, and also to address whether in Parkinson's clinic there's some extra work needed there. Patients with Parkinson's have a very high incidence of developing dementia. At the moment, when we've run an audit, out of the 272 patients with Parkinson's that are coded in primary care, only a very small number of them actually are coded as having dementia as well. So we wonder if maybe there's a little bit of work needed there to see if the cognitive impairment that's in these patients with Parkinson's hasn't yet been identified as potentially dementia. We've also had joint meeting between all three services through the mental health team for older persons and the hospital consultants to trial a direct referral pathway for the very small number of patients that are picked up in hospital where the history is not a delirium, it's a clear dementia, to see whether we can cut out the need for a GP referral. We're also looking at reducing the DNA, the dropout during the memory referral pathway. To give you an example, Kathy, the memory nurse, identified 242 people in a 12-month period who had concerns about their memory. At that first point of her then inviting people in to be screened, 50 of them decided they didn't want to go ahead. At the next step, when they were identified as one offering referral to the memory clinic, again, we had 30 of them decline to go ahead. So you can see that at each point in the pathway there's quite a bit of a dropout. And we've talked with Public Health and with Helen Raisin about, and we've done a little bit of looking into, is this around stigma? Is this about people needing more support to get through the pathway? And so I think there's still more work to be done in that point of view. So on the next page, really, if you were to ask me where I feel our priority needs to be and where the main efforts need to continue so that we can achieve this, I feel the care home population still is potentially a source of patients who are have dementia and haven't yet been identified. I feel we need to keep dementia and awareness of dementia high on the education sessions for GPs at the half-day training, so that when patients are presenting, they're definitely getting referred and they're being supported to get through that referral. And I'd also like to follow up on the work that Public Health did for us in looking at stigma and how reducing stigma and activities may help. And I think it's imperative that we keep working together with primary care, secondary care and mental health teams. I don't think there's any one answer. If there was, we would have found it by now with the work we've been doing. I really do think it's going to come from joint working across these fields.
Great, Nerida, thank you so much. There's a lot of work that's gone into this to try and help with the diagnostic rates. Just to reiterate, the reasons for trying to make sure that you've got the numbers on your books is that you're not that those patients aren't necessarily missing out on services that could be provided for them to help support them in the community. So that's the main reason. It's not just about a tick box exercise in this. I've got a few questions I've got to ask, but I just wonder whether any other board members wish to just ask Nerida. Sorry, Naeem.
Nerida, I know a lot of hard work has gone into this piece of work. You mentioned that there are about 80 patients who have been identified as possibly having dementia, and a referral was recommended to them, but they turned it down. Have we followed those patients up? Because often when patients are offered a referral and they decide against it, 3 months later, 6 months later, they might change their mind. Presumably we're chasing these patients up.
So they remain on a list that Kathy, when she comes back to visit the practice, follows up again, just like she follows up the patients who've been discharged from hospital and may have chosen not to attend. So yes, they're on her radar definitely, and that's by each practice.
Yeah, I think they're a vulnerable group, and they do need to be identified and followed up appropriately.
Thank you. David.
First of all, I think it's an excellent report. This has been around now, as I've been listening to conversations with clinicians for 18 months, 2 years. Can you hear me? I have a very low voice at the moment, even compared to normal, because I've got the flu, so I'm staying well away from you all. But I can still do a little bit of talking. Yeah, and this is exactly what I think we needed, because this reads to me not so much an addressing of the issue about how many we're short of against the target, which I've never accepted the legitimacy of that in the first place, but rather the notion that we have to ensure that our protocols are absolutely in place to provide the service that's expected in the community. And I think this does precisely that. So I'm reassured, I think it's excellent, and I think that the actions to prioritise are absolutely spot on in terms of moving this forward so that we don't lose sight of it. But I'm less worried about the 85 and the statistical aberration, which is what I've concluded at the end of listening to the conversations over the last 2 years.
Great, thank you. Gareth.
Thanks, Nerida. I reiterate what everyone else has said. There's a lot of work gone into this. I probably mentioned it here before, but probably not to you. I just wondered if there's particular groups that have lower prevalence that we'd expect, and I'm particularly thinking about the BME groups in Kingston, because traditionally those elderly patients may not be in care homes, may be more likely to be looked after in the home by the families. And I just wonder whether there's any data to show that we have, whether the rates in those specific ethnic groups are lower than we would expect, and if so, would they be a particular group that would be worth targeting or worth looking into in more detail? And I know it's not always easy, particularly with language issues, but I don't know if there's any data on that.
I think there's quite a few issues around several things that you've mentioned there. I've often surmised that some of the hard-to-reach nature of our population is that some of our patients, excuse me, are managing, and so they're not coming to attention, which is partly why that patients not being seen by their GP over a period of time might be some of the unknowns. Included in that might well be people being looked after by an extended family very well and not needing extra support. The hard-to-reach groups, by definition, are hard to reach. And so there is quite a bit of work going on, not locally specifically, but with the Alzheimer's Society around BME groups. We know we've got several populations in our community who are underrepresented. Mostly anecdotally, we know they're underrepresented, namely the Korean community. But when we've talked with public health, locally with the public health team about it, some of that is more they're a working age population, even though they're a large community, so perhaps actually dementia is not so significant for them. But there are other parts of our population, like the Tamil population and some of the Southeast Asian population, who will be at higher risk of dementia because they've got higher vascular risk factors for other things like diabetes and other heart disease. So yes, it's still a question that's there, and any suggestions or options of how you feel we can work with the community, very gratefully received. Yeah.
Thank you. I just wonder, have we got any statistics, any numbers? You know, is it particularly that the Tamil the prevalence of dementia in the Tamil patients is lower than we would expect? And then maybe we could target those practices that have a vested interest in this from my own surgery, but whether we could target those practices particularly, or whether it was another, you know, can we get that data from Brian, do you know? Or
I think some of those things we can go through, but some of it's a little bit harder. For example, Brian was able to help with Sarah to find the Parkinson's, for example, for me, and that's clearly there's some issue there. So I can't see why, even at a practice basis, if you weren't able to. I think I've often been told, however, that we're not brilliant at coding ethnicity either. So the search will only be as good as the coding has been. But if you're pretty good in your practice at coding ethnicity, I don't see why we shouldn't be able to do a search in the practice on a practice basis to find that sort of rate. So I think these are the sorts of solutions we were meeting with each practice to try and see if they had a feel for where the issue might be in their individual practice.
Great, Sarah.
So this is a really challenging one, because I know that actually from the time that I've been in South West London, one of the questions I've been asking is, why is Kingston not achieving this? Because everybody else in South West London is. And one of the things that I was told was it was because the prevalence was out with everybody else. And I think what you've said here is it isn't. And I think that's a really important message. I suppose my question is how do we turn this around? Because this is the only area in South West London where we're not achieving this. And actually, Kingston's performance overall is good on nearly everything. And this is the only thing where we're really struggling. And we actually need to make sure we put the resource in the right place to make sure we can achieve this. So I suppose my question is, what do we need to do differently now in order to achieve this? Because I think there was a perspective that actually we couldn't achieve it because it was just about the prevalence. And I think if we can dismiss that, then the next question is, so what can we do to make sure we do achieve it now?
Agreed.
Yeah, I'm asking the question.
As I say, you know, in my final slide, that's my perception of where we need to put the emphasis. The care home project, I think it's been talked about before, but just briefly, if it hasn't, it was something that I did 18 months ago, where I approached all the care homes to meet with the managers, explain the problem that I felt, could there be people living in your home that haven't got a diagnosis? Out of the 18 that we approached, I managed to arrange a meeting with 12 of the care homes. Out of those 12, I managed to get a list of patients that they felt would benefit from a review from 6 of them. Out of those 6 care homes, there were 31 people identified for me to review, and out of those 31, I diagnosed dementia in 23. So it's quite a high hit rate. There's 12 nursing homes or care homes that didn't provide a list. There's a potential that there's more patients there. I would still argue that that is something that is worth resourcing again. And the care home population is a fluid population. There's new people moving in all the time. And so I've passed that over as one of the action points to each GP practice when I visit them, because I still see that as one of the potentials where there is a bit of a group that we maybe haven't found. But the rest is very much ongoing work. And it's working out where we need to improve systems and pathways, where we need to improve access for patients to get what they need. And I think that will come through the joint working that we're now starting to get, but it's taken time to get everyone around the table.
So I suppose my suggestion would be that I think this is a really good piece of work and that we've done the analysis, that if we don't start to see the improvement quite quickly, I think perhaps we need to think about what different do we need to do and what kind of additional support can we get in to help us to do this, because I think we should be able to, I suppose is my...
So, sorry, Ione, do you want to come in?
I mean, I would definitely pick up on the point of a multi-prong attack. I don't think one thing is going to get us over the line. I think we have to do all of the things that you've said in there, Nerida, and absolutely support the work you've been doing. I think the element around stigma it will be difficult to tackle, but Kingston as a borough is a dementia-friendly borough, and how we turn it into more of a, doesn't have to be all bad news, I think will help those people that are resistant to actually go to the test and get an answer from it, or that's their perception. I don't know if there's other searches we should be looking at where you've got two people aged over 85 in a household who are probably propping each other up, don't particularly want to have services involved because they think it's all going to be doom and gloom. There may be other cohorts that are just coping until one or other tips over. And I wonder about some of our other elderly care provisions, so working with Stay Well, again, people that are not in care homes, but perhaps having quite a high level of support, so some of the day centres that Stay Well run, for example. Again, whether in that sort of more nurturing environment, whether we could take some of it out to them rather than feeling they have to book in particular clinics. I think things like that might be part of the sort of action plan that we could work on together.
So that was going to be one of my points, was around what we're doing around the borough voluntary service Stay Well elements to try and link in, because they've probably got an awful lot of data on patients who may well be diagnosed with dementia or having high needs because of cognitive problems, but we're unaware of it on the health side because they're being cared for within the community. So that link in sounds like a very good link in. There are a couple of other points I just wanted to just bring up. The prevalence, the diagnostic rates changed when the prevalence went from living within the borough to a registered population, and we dropped. So does that indicate that we've got a real problem around our edges and around outside the borough boundaries of patients that we are not exploring?
I don't know what that means, to be fair. I think it's quite hard to know. I guess the change in the prevalence should have made it easier for us, because actually they are all known to us. They're all the ones who are registered with us. So it was before, it was more difficult.
But if you look at the borough population compared to the registered population within the borough, I think there's about a 30,000 discrepancy. So there's an increase in population, and if we're increasing that population, that means we do have those people around on the outside of the borough boundaries, which means that maybe they are the ones that are actually falling out of our view. When it comes to the diagnostic bits. There's a couple of other points I can make, if that's okay. I know personally of 3 patients who have dementia but just don't want to be diagnosed with dementia.
Yep.
I think the other bit was around the care homes. I think the diadem tool was really useful to be able to make the diagnosis for those patients who are probably bed-bound, home-bound, who do not wish to go to outpatients and get that diagnosis. So you can actually use the diadem tool. And a lot of the practices actually do annual reviews of their nursing homes and residential homes. Maybe it's a case of just putting it out towards the practices when you're doing those annual reviews, going down the patients, actually doing that question: does this patient have a diagnosis of dementia that's not actually being coded?
Yes.
So that might be another element.
And I would support, in the pack that we took round to practices, encouraging people to reflect on the advantages of getting a diagnosis, even in advanced dementia, even in a person in a care home environment. It's still very helpful for advanced advanced care planning, it's very helpful for admission avoidance, and it's also helpful for anticipating delirium, which are all clinical difficulties that we come across, but if we've got a known diagnosis, it's incredibly helpful. So we've passed that on to the practices. I think it's keeping it in people's awareness, and whether that's through the education sessions or what it might be, whether it's some sort of incentivising of practices to include that in their reviews, yes, I think that's all helpful.
Thank you, Tonya.
So thank you, Nerida. I think it's myth busted some of my assumptions. So a couple of points. I think the bit about not being registered but not resident is really interesting, isn't it? So unless those people are going to their GP, you're not going to pick them up. So actually, I think it's maybe some work with practices who have a significant number of patients registered with them who are not resident in the geographical boundary of Kingston. So there's two pieces. I know, Naeem, that's one of you, but also the Ham residents. So we know we've got a lot of people who live in Richmond that so actually, and thinking through those practices, is there a way that we can capture that? I think, but I know what, and I think it was Sarah said. So you've identified what you think the next steps should be. We need a concrete action plan that says what are we going to do and how is this going to be resourced. It needs to come back to the governance, the new integrated governance committee. So I'm assuming, I haven't seen it, I must admit, there is an action plan. I think there needs to be a more resource. So if there's a resource that's required for the care homes, we need that absolutely identified and costed, and with a clear commitment from the CCG governing body to meet that resource requirement. So can I ask, and the next one's in January, so it might be too soon, but can I ask that goes to the February governance committees, and that the integrated governance committee, quality committee, and that's report to the March governing body about what the quality committee has agreed to resource. Because I think what I'm hearing is there is some things that we need to do, but it needs to be resourced. And I think the governing body needs to then commit to that resourcing. Because you're absolutely right. Every other CCG who has had the same challenges that we have has made that target. And whether they've been able to resource it or I don't know the answer. So we need to get a grip of this, don't we? So I think if we can do that for the next, so the March governing body, we will have a resourced plan with timeline and deliverables to go through the quality committee.
Can I just ask one question? Has there been some learning across South West London with the areas that have actually achieved their targets? Have you had those discussions as well?
Network team come out from NHS England to visit with us. They share the learning from across London. So in answer to Tonya's point, it's been different problems in different areas and everyone's had different solutions to find. We've done everything they've suggested, but I think it's just more of the same, and I think it's just ongoing more of the same. I don't think there's any one answer here. I think it's going to be just ongoing work. But yes, they share the learning with us, definitely. Yeah.
Catherine.
There was just a couple of points, really. One was around the care home piece. My understanding is that care home staff can be quite transient and move, and therefore the quality and the ongoing support to ensure that people are really up to speed. I know in certain areas, and I'm sure it's no different in Kingston, that's an ongoing training and development. And I'm sure that that's something that's being considered. I think the other is around the kind of training and development for all staff, something of particularly, say, clinical pharmacists and others who are looking at sort of medications reviews and others. I don't know. It's good to sort of see that it's education sessions at GP half day, but having obviously attended myself, you're not all necessarily capturing all members of the practice team. Yeah. The other element is around the comms and the marketing piece, and I don't know how strong that is. I'm certainly in my own GP surgery. I don't see any evidence of information that might be useful. So if I'm somebody who's, say, considering caring for an older parent, that might be something in terms of prevention I'm needing to kind of start to think about and be aware of some of the early signs and thinking about that. And the last bit really is around that idea around learning from other areas. I'm just mindful of some of the work that's been done in Bradford and Midlands and East, particularly where they have certain large populations where, you know, particularly where older parents are cared for more at home with their own families. And I'm wondering if there's sort of, you know, some areas of learning around that. So it's just some comments really.
So just in reply to your observation of the care home environment, certainly in doing the care home project, there's a marked variation in enthusiasm and knowledge amongst the staff. Those who got the idea of the project were very supportive, but I think it would be even better received if it was done by GPs that were known to the individual care homes, because I think that was often the question I got, well, have you checked with the GP? Do they really know you're doing this? Which of course I did, but that was always their thought. So I think a good relationship between the care home and the GP looking after that care home would be really valuable. The information in each individual general practice, we've done some brief posters to advertise Kathy's presence, and I know the Alzheimer's Society and Staywell have got some bits and pieces. I think it's always hit and miss, isn't it, what you see and what's available to you, but yes, they're fair points. So yes, the sharing of learning, we're always looking out for new ideas, so thank you.
That's great. Rob?
The aging parent, she was 93 this month, right? Last year, your healthcare, she was assessed by the contractor from the council. Their dementia nurse or expert has been off on maternity leave for months now, so she wasn't assessed by them. So eventually, Dr. Nassif, our autism practicer, it may have been Kathy. We sat down with this excellent lady, and the report she produced was excellent. So maybe if you've got all the people that have been looked after by your healthcare for a start, and maybe go around and assess them. So that's maybe one aspect. But also, I feel that these are all hidden by relations and their partners, really. And maybe if you had like a number like we have within the cancer thing, a number you could bring, where you could, if you've got a worry about, concern about dementia, that you could bring this dementia line and get hold of Kathy, might be a good start. And also in the doctor's surgery saying, look, don't be stressed. There's someone to help you and go along that sort of line that you ring this number and to get assessment. And also with the home business, I mean, have you included the 4th floor of Star and Glass, which obviously that's their dementia floor, so you've got a few number there straight away, you know. But yeah, I think there's a lot of people out there being masked by their relations and their partners. And I mean, things like she's got the odd button thing. If you went to the telcare people and said, no, this is the old people in Kingston that have got the panic button, that might be a start. Certain people to look at that are a bit, need looking at maybe because they're not unsure being on their own, things like that.
Yes, we've got to be a bit careful how we share which lists of patients, but certainly there are all ways to look at. Yeah.
Obviously, I'm sure if it's within an organisation.
Rob, that's really helpful. Okay. I think it's a great piece of work, really. You've done an awful lot of work to try and bring the levels up, the prevalence up. There's still an awful lot that needs to be done and taken on board. Tonya's point around making sure that the committees are actually looking at ways of being able to commission the services that are required to actually try to identify those extra 80 patients. But to tell you that, but just to reiterate, this is not because of a tick box exercise. This is to make sure that those patients are able to have access to the services that are required by them to help support them and their families. And so it is a case of identifying those patients for a purpose. Okay, but it's really good work doing that. So I'd like to thank you, Nerida, and your team. Sorry. Thank you, Rob. on that note, we'll move swiftly to the other age spectrum, to the CQC SEND inspection and the next steps. So, Julia, will you take this on board?
I'd like to welcome Doreen Redwood, to the governing body. Doreen is our Children's Lead Commissioner, and Doreen is going to talk to us about the outcomes of the recent CQC SEND inspection that we had in Kingston that was undertaken in September of this year. And the CQC's assessment of Kingston SEND's provision was that we required improvement, and a written statement of action is in the process of being developed. We've submitted one copy, and we've had comments back from that recently, and we're working further across partners in the borough to take that forward. But this afternoon, Doreen's going to reiterate the roles of us as a governing body and pick up on those points and those areas that very much fall in our responsibility with regards to this inspection report and the actions we need to take. But of course, we are doing this in partnership, working very closely with the council and with AFC, Achieving for Children, who are our main provider of children's services in the borough. And of course, we also need to think about those children that are in schools, and of course, South West London St George's, who provide elements of the mental health services for our children and young people. So I'll hand over to Doreen, who is our expert in this area.
Thank you, Julia. Just to bring the governing body's attention to the report and focusing on the background in relation to the report. The SEND inspection letter, which is attached as Appendix 1, outlines the strengths, and it is, I think, helpful to identify that there were some strengths, but also some significant areas of concern. And those significant areas cover kind of four big key areas. The first area around the poor quality and monitoring of education, health and care plans, including the contribution of health professionals. The timeliness in terms of ensuring that the annual review process and amendments to the plan are made consistently and in line with the Code of Practice. Of particular concern is the strategic leadership and monitoring of the CCG in terms of implementing the 2014 reforms, but also having a very productive and positive relationship with the Parent-Carer Representative Forum. So at the previous governing body meeting, the report that was submitted outlined the kind of key areas where the CCG had responsibility for, and those are listed under paragraph A down to I. Essentially, those concerns have achieved a range of implications and the need for the CCG to do a number of things. Essentially, to increase the designated medical officer time, because that is a key role in ensuring that the CCG meets its strategic responsibilities. The need to strengthen that strategic leadership and accountability, and that can be done in a number of ways in terms of the governing body receiving assurance through various monitoring reports, which will enable the kind of scrutiny and challenge of the SEND reforms to ensure that the statutory responsibilities are being met. The CCG will also need to review and strengthen its joint commissioning arrangements, and that's essentially the work that is undertaken with the local authority through Achieving for Children, essentially. So what is the current position? So since November, we have done a number of things. The designated medical officer role, the additional funding has been agreed to increase the number of programme activities. So previously it was 1 and it is now 2, which is the recommended national amount. Agreement has also been achieved for recruiting a designated medical clinical officer. And essentially this post is the kind of operational arm in terms of ensuring that the reforms are achieved locally and operationally. Quality assurance, as you can see from the written statement of action, that quality assuring the contributions across all partners in relation to education, health and care plans is a key way of really knowing whether or not the work is of high quality and meeting the needs of children and young people with SEND. Strengthening those joint commissioning arrangements, and there's been an establishment of a strategic Kingston SEND Partnership Board, and that will be chaired by the Chief Executive of Kingston Council, and the CCG will be a member of that board, and essentially the CCG governing body will receive regular reports from the board, and this will also link with the Health and Wellbeing Board. The other key strand is the SEND transformation programme, whereas Achieving for Children have developed a 3-year transformation plan, which really sets out the challenges, the context and the actions that need to be taken in order to really begin to understand demand, manage that demand and respond appropriately. So what are the next steps? Well, essentially, we are producing the written statement of action, which is essentially an action plan, and we are doing this jointly with partners. And as Julia mentioned, work has been ongoing on completing the first draft of that. And the final written statement of action will need to be produced by no later than mid-February. As the governing body, one of the ways of demonstrating high-level commitment is to include within the Constitution a phrase or a set of words that really demonstrates and evidences our commitment to commissioning high-quality services for children, young people, families, etc. with SEND. The other key strand is around identifying and being clear about having within the governing body a SEND champion that will provide the real link between the CCG, the designated medical officer and the designated clinical officer. In relation to the designated clinical officer, work has already commenced to start the recruitment, and that should commence fairly soon in the next few weeks. The other key area of work is around the Section 75 agreement, and again, as we do normally, review the agreement, but being very clear about our joint commissioning arrangements. And following on, in terms of really embedded the service improvement, one of the things that we have to do is to underpin this by a very strong co-design approach with parents, carers and children and young people. And so, for example, one of the areas that was raised within the inspection report around the 0 to 5 neurodevelopmental pathway, there is work that we can do to co-design that with our parents and our children and young people, so we can begin to address this area of concern. One of the other key areas was also around improving access to therapy services and also reviewing the local offer. And again, this can be done in conjunction with parents, carers, children and young people. But generally and strategically, improving that engagement with parents and carers so that we can begin to understand the issues around the SEND agenda and also have that ongoing dialogue. So essentially, the governing body is asked to note that the written statement of action is work in progress, that we need to clarify the role of the governing body SEND champion, and also to approve the inclusion of some kind of formal statement within the Constitution and really to note the current progress and next steps.
Doreen, many thanks for that. Comments, questions from board members? Sarah.
So this was a very serious report. I think the governing body needs to take it very seriously, and I think that we need to take the recommendations on board and see what actions that we must take in order to make sure we put this into a better place. On the bit on the Constitution, I'm not quite sure that's right, to be honest, because I think that might be a lack of understanding of how the constitutional arrangements work for CCGs. What I think we could do is offer CQC and the Ofsted something else which might be around how we prioritise this across the CCG and put that into our priorities going forward. You know, it's just practically, this gets signed off then by the membership and then it goes through NHS England. There's a whole process around constitutional change, which is a governance process. It doesn't put out priorities for individual services. But I think we can work with them on that, because I think the important thing is that we show how this is an important priority for us and that we are willing to do the right thing. So I don't want that to sound negative. I think that I would want to do it in a way that absolutely shows that, but that might not be the right route, is what I'm saying. So we can work with them on that. But other than that, I mean, this is obviously very serious. This is something that we should take very seriously, and we need to absolutely put the right support and resource around this, and make sure that we take this forward in a way that makes sense.
Great, thank you. Any other comments or questions? Right, Tonya.
Absolutely echo what Sarah has said, and I personally met with the Managing Director of Achieving for Children, Ian Dodds, on Friday, with the Director of Children's Services for Kingston, and agreed that we want, and I will be meeting with them on a regular sort of monthly, 4-week, 6-week basis to make sure all the actions that we agree are take forward, and how we do this in partnership. And actually recognising how we come to decisions and agreements together. And one of the areas that we did agree, we need to look at the awareness raising with GPs around what their role is, and actually how we can help them support those sometimes quite difficult conversations with parents around the need and want, and actually that sometimes is quite challenging for our practitioners. So absolutely, this is really, really important, and anything that comes out of the partnership board we will consider carefully, but in partnership with the people that sit around the board, to make sure that we move forward in a positive way.
Catherine.
It was just I'm losing my voice. It was just going back to page 5, which is the kind of comment around the overall poor quality and monitoring of the EHC plans, including contributions from health professionals. And I'm wondering what's being done to address that. I think that's my first point. Second is, how are we going to sort of rebuild confidence with parents and develop that relationship? Because obviously that can be broken and that can take time to build back up again. And the third one for me, which is a little concerning, is around on page 6, around point B. So although children looked after who have SEN or disability are still not having their initial health assessment carried out within the statutory timescale, I know that's not necessarily having an impact on them receiving health care. However, I am concerned, considering the numbers we have of lack within the borough, why this is an issue.
Okay. In relation to the first point around the poor quality and monitoring, essentially that is around a number of things in relation to the advice on the education, health and care plans. Now, essentially, it is ranged from not providing adequate advice in relation to that child or young person's needs, or it might be that critical information is missing within the education, health and care plan, or it might be that those professionals who provide the advice are not able to present the information in a way that makes outcomes very clear. So there is a clear training programme being developed jointly with Achieving for Children to provide training for all staff. That includes education, schools, health, etc., including social care, about how to write the advice and information within the plans. So that is part of the written statement of action. In relation to the Parent Carer Forum, for those governing body members that are not aware, there was a group called Send Family Voices, which decided that it would close in September, and this has now left a void. And we now have a national group working with Kingston parents in order to decide the next steps in terms of pulling together whether it's a joint group across Kingston and Richmond, as this previous parent group was, or whether it's a existing Kingston group, or whether it's a consortium, or whether it's a new parent care group. So that work is currently being undertaken by Contact a Family, and hopefully we should have some form of representation at the end of that process. However, there is commitment from the CCG and Achieving for Children to work with various parent groups across the boroughs. So we are not only relying on one group, but we are seeking the views of a range of groups. So I think that covers a couple of issues. In relation to the question about initial reviews, I mean, unfortunately, this is quite a kind of complicated one, because in order to provide the initial health assessment on time, that requires information to be provided by, for example, social workers. And in process terms, there have been some issues with notification. So once the service receives notification, then absolutely that work is done, but it's dependent upon a whole process. And unfortunately, as part of the inspection, they were looking at the whole process. So even though health colleagues were doing the work on time, the actual point of referral to them was taking longer than the statutory timescale.
Okay.
Well, can I check that? Well, is that going to be addressed as part of
That's all being addressed as part of the written statement of action.
Thank you.
Sarah.
So I'm going to suggest, because I mean this sets out the report, but there will be a detailed action plan. I think the governing body needs to have oversight of that as we go forwards. I think the governing body needs to take this very seriously. So I think we need to regularly receive updates on the progress of this against the requirements and the reports that we're then receiving on it. I don't think we've had the level of oversight that maybe we should have done on this in the past because of, us actually getting to this point. So I think we need to make sure we have really detailed oversight of it in the future.
Thank you, Liz.
I think another issue that was picked up in the initial report that I can't clearly see here was the under provision of therapists, occupational therapists and physios and so on. And I couldn't see anything in this particular paper very clearly. Sorry if I've missed it. And I wondered what progress is being made on that issue.
So it is one of the areas that's briefly mentioned, Liz, but one of the pieces of work that was parallel to when the inspection was being undertaken was a piece of work that Achieving for Children commissioned around a review of therapies. We now have quite a large working document, which does a gap analysis and looks at therapies across both the Kingston and Richmond space. There's something about unpicking that. So we are going to be using that to look at what we need to do in terms of the therapy services we've got. The other thing we do need to do is look at the integrated disabled children's service model that we have with the council, which brings the therapists together with other professionals as part of that review. So that was one of the actions that we put into our plan. We were working on this yesterday in terms of the long list of activities. So it is work that's there. It's not been forgotten, and we're aware of some of the shortfalls, and also the fact that there are different commissioners that commission different elements of therapies depending on whether it's an educational need or a health need. So again, there's something about looking at all of that as part of that, but it's certainly there.
Okay, Iona.
I'm just going to echo the seriousness of this report, and I think the fact that Ian Thomas, our incoming chief exec, is going to be chairing the board is, echoes the importance with which the council also holds this. And I think the whole partnership working between AFC, which is part of the council reality, I know it's had a sort of arm's length feel to it as a provider, but the recognition that's not a model for us to be working in partnership going forward. So I think between the wider council, AFC, and the CCG, in order for the action plan that we're developing to work, it means much closer collaboration. So, that's certainly an intention, and I think Ian will clearly be taking this very seriously when he comes in February. Around the therapies, I think it comes under service improvement 3.6, and again, that recognition of a need to look at that and strengthen that, but in the most effective way, given we recognise it's a scarce resource. It's actually quite difficult to fill some of those posts, so we need to be upskilling other members of the workforce as part of that too, but I know that's part of the plan going forward. The Health and Wellbeing Board are also looking to have regular reports in terms of the implementation plan, so that would match quite well. Hopefully we can write one report that comes to both the CCG and Health and Wellbeing Board.
Thank you, Iona. Tonya.
So I think it is really important that we have the governing body continues to have oversight. So I suggest that we have this as a standing agenda item until we're to the point when we feel that we can add it back. So we will have it as part one standing, even if it's a verbal update. And I think the therapy, and that's one of the long conversations I had on Friday, and it's about how we collectively agree the model. And then are we optimising the use of the resource that we already have in place? And then we talk as a partnership about how do we close the gap. So I think it's really much moving into that more partnership approach to solving a shared challenge that we have in this area. So, and that's the kind of thing that we'll also report back regularly to the governing body on every time we meet during this year.
Okay, thank you. Any other board members? Rob. I think it's a really important note, Rob. I think that it is really important to know that we are taking a variety of different measures to be able to get that feedback so that we know that things are progressing in the right way. No, I completely agree, and I think that has to be a part of it. I do understand that this is still very, very early stages. There's the Education Commission that's actually meeting to actually go through an awful lot of the reports that have been brought through. There's an awful lot of work around the written statement of action that's going through. So I think that you're going to find that when we do get the reports coming through to the governing body, we need to be assured that progress is being made, and that actually those, exactly what you're saying, those steps and points in time whereby we're actually getting information back from the parents, the carers and the pupils that things are starting to improve. We do need to put those measures in place. Not yet.
I'm aware at the time of the inspection there were a very few EHC reports that needed finalised, but I believe now that they have completed all of them.
Okay, unless there's any, because I think it was really important to spend time on that and actually get the information report on the written statements of action. Unless there's any other comments or questions that the board members need to put forward. So if I can just summarise that the board is being asked to approve the direction of travel that this is being taken, to make sure that part of our priorities going forward are specifically towards the SEND rather than embedded into Constitution, agreeing with the increase in DMO time and also the DCO post, making sure that we get regular reports coming back to the governing body, and this is being underpinned by a quality assessment framework. We need to make sure that there is a strengthening in the joint commissioning, and also that we need to have a discussion around the SEND governing body champion. So what I would suggest is around the SEND governing body champion, we take that outside this meeting, we come to a conclusion and we bring it back at the next governing body meeting for approval. So are people happy with that direction of travel? Yes? Okay, thank you, and thanks Rob. So if we can come to the Integrated Governance Committee report, please, Fergus.
Thank you, Chair. So this is a report that's familiar to the governing body. It covers the South West London performance report as well as the CCG report, and also covers the feedback from the 20th of November and 18th of November committee meetings for Kingston CCG. There are three broad parts to the report: the latest performance assurance report, including our operating plan supporting activity, our latest improvement and assessment framework dashboard, the latest quality premium. I think the key points that I want to bring the governing body's attention to, I think we've talked about dementia already, so I won't go into any detail on that. There are a couple of very positive continuing performance areas, so particularly around mental health and our referral to treatment and cancer targets we're doing extremely well on as a CCG, and all of our activity performances within the operating plan expectations, with the exception of GP referrals, which are above plan. Tony mentioned in her Managing Director's report about the work that we have been doing as a system to support the performance of the accident and emergency standard. At the last governing body, we had a detailed update on where we were at with our winter plan and the assurance process around that. And do want to say, although it's early in the winter phase, as a system, the partnership work and the collaboration day-to-day operationally has meant that we're performing as we had hoped and as we'd expected, which is short of the 95% standard, but as a system we said that we were aiming to achieve and sustain 90% on a regular basis. And as a system, we're doing very well in that regard. And partly that's with the support of our local authority colleagues and the work that we've been doing around placing patients without prejudice, which is getting them out of hospital quickly into the appropriate setting, the focus that we've had on delayed transfers of care, and the support and partnership from our community providers as well over the working week, but also at weekends. So whilst A&E performance is not at the level that we would want it to be, as a system at this stage we're coping well, and I think again just want to stress the importance of our partnership work in that regard. Going through the report, you'll see on the summary page there are a couple of small areas, a few number of areas where there are red performance indicators. The mixed sex accommodation breach and the A&E waiting times I've captured within the actual narrative itself. The improvement assessment framework I think is largely the same as it has been from the last governing body. And then on page 15 of the report you'll see that we had a wide range of clinical quality review, let me just say that again, clinical quality review group meetings during the period. The one that I would draw to the governing body's attention is around South West London and St George's Mental Health Trust, where some of our quality team and the senior clinical and managerial staff from South West London and St George's took the opportunity to do a tabletop review of all of the open serious incident investigations at the trust, to look at whether there were any particular themes or trends arising from those, whether that be through the location of the service or the types of patients that were affected by those. And a further report will come back to the CQRG in due course for that. In terms of our operating plan performance, one of the elements within the quality premium on page 14 is about the need for us to ensure that our patient tracking list target at the end of this year is no greater than the the position at the beginning of the year. So we wanted to have, at the end of the year, no more patients waiting for treatment than we had at the beginning of the year. It is still red rated, and Yarlini is going to talk a little bit more about that in a short presentation, which talks about the underlying reasons for that. So rather than steal her thunder, I will pause here and say I'm happy to take any questions.
Sarah.
So just on our RAG rating, I just wondered whether we might need to review actually how we present that. Just we have very few that we're not green on, which I think is great. But it's just on things like the dementia diagnosis, the actual miss rate is actually higher than it is on the A&E, but we're amber on that and we're red on the A&E. So I just think we might need to just have a think about how do we present this, because it looks as if we're in a better place, I think, on the dementia diagnosis. Actually, it looks like we're in a worse place, I think, on the A&E than we probably are at the moment, because we are meeting the 90, or just we have done at Kingston anyway. So I just think we might need to think about just presentationally whether or not we've got that quite right. It's really obvious when you've only got a few that aren't green, to be honest. It's probably the same in other CCGs, but you don't notice it so much because it's more green and more red and amber. But it's really quite noticeable.
I'd take it on board. Thank you.
Right. Any other comments or questions around the IGC report? Catherine.
It was just on page 12, Fergus, around the completeness of the GP Learning Disability Register. And I just wanted to find out if there's a timescale for this, because I know that there's currently less patient numbers on the register than expected. And I'm just mindful that obviously there's support in place to try and improve that. But is there a bit of a timescale on that?
There's just been established in Kingston a Learning Disabilities Partnership Board, which is being supported by Health Watch, and one of the sub-programmes of work is called Health and Wellbeing, and that has the annual health checks within it. That group is being formulated, and then they will be developing the scope of that. So at this moment in time there isn't a timescale, but we can come back to you on that. But it's an ongoing issue that we do discuss, and it's one of those other areas where if we were looking for a GP, we're looking at clinical lead also to support that, and we're in the process of formulating a job role for discussion.
Yeah, no, we were quite aware that that has been an area that's been lacking for a while, and we are in the process of actually making sure that we do have a clinical representation, because I think actually having a clinical champion on the LD will really promote some of the work that's done in primary care. Okay, any other comments or questions around the IGC report? No? Okay, Fergus, thank you. So if we can come to the finance report, please, Yarlini.
Shall I just briefly take you through the elective activity report first? I won't take very long. This is a South West London report, but I'm going to just focus on Kingston. As Fergus has told you before, there is a requirement, or there's an expectation that the RTT patient tracking list size should be sustained at a March 2018 levels, and we were meant to hopefully achieve this by March 2019. As the year progresses, it becomes increasingly unlikely that we are going to achieve that, and you can see that in Fergus's report on the quality premium dashboard, we haven't taken account of the fact that we are going to achieve this, and that's why we have that 50% reduction. In terms of just going through some of the reasons why, we are seeing increases in demand in referrals at Kingston Hospital for Kingston patients. Predominantly, most of these are actually due to increases in cancer referrals. I suppose the thing that we do need to be mindful of, though, is the growth of the referrals and the growth, whilst it correlates with the growth or the increase in the PTL, actually there is more on the PTL than there is in terms of growth, of the referral growth. So it's just trying to work through that. We in terms of how we're doing the demand management, we're working with practices. All the practices, as you know, gets a data pack, and we work through and look through usages, outliers, and look through how we could potentially try and bring that down. In terms of the long waiters, the positive thing with Kingston Hospital is that we actually do not have a problem with long waiters. Although we have seen an increase in the waiters between 40 and 51 weeks, but actually that is primarily due to some of the increased work that has happened with Kingston helping out St George's. So that's some of the detail behind the elective activity. So happy to take any questions or move on.
Okay, I've just got a quick question around the increased referrals on the 2-week waits on cancers. We are also getting some feedback from the trust particularly around dermatology, and so that's the reason why I think that we're starting to look at ways of being able to do appropriate referrals. The dermatologists have asked for us for primary care to be trained in dermatoscopes to try and reduce that to reduce that referral rate.
Yeah, no, you're absolutely right, because that's one of the specialties that we've seen a large increase in. So anything to help mitigate that would be really useful. So thank you. Okay, so if I can come on to the finance report. You have the month 8 finance report in front of you. Kingston CCG is still doing very well. It's quite nice to see a sea of green on the finance scorecard on slide 3. In terms of meeting its business rules for 18-19, we plan to meet all of those. The thing that we have achieved since the report's been written is that we have secured a year-end deal with both Kingston Hospital and Epsom and St Helier Hospital. So in terms of trying to de-risk the position, we've done quite well at trying to manage that. So when we look at the risk and mitigation slide, I think it's on slide 16, actually the further risks that we have in that column are much reduced now. So I think we're in a good position for that. We've consistently held well in terms of our non-acute, although we have seen a slight increase in the increase in costs for children with disabilities. That, however, has been managed within the position. So I think we should be able to comfortably close for 2018-19. In terms of next year, as you know, we are still waiting for the allocation to come. We have some snippets of information that gives us ideas on what to expect in terms of the 10-year plan that landed with us yesterday. But until we get the allocation and work through it, we still are not able to present anything concrete to governing body. We suggest we'll bring this next time as soon as we have the information. No, I just had a quick check. Despite not receiving the allocation, we are still expected to do a activity submission for Thursday. And what is comforting is actually the work that we are doing as a system level. So we're working with all the stakeholders, community, acute, and trying to understand the activity and demand capacity management that we'll have for next year. So we've taken a pragmatic review approach to how we're doing our first submission on Thursday, as we are still slightly in the dark for some of the information. But again, we'll bring the more detailed one back to you another time. So happy to take any questions.
Thank you. See, it seems like it's good news.
It's positive. It's positive for 18-19, yes.
Yeah, so you're not always a black cloud. So
no, I'm not always a black cloud.
Any comments or questions from board members around the finance report? No? Okay, thank you, Yarlene. Okay, so if we can come to the councillor members' report, Atin.
Thanks, Chair. Since the last governing body meeting, we've met, councillor members has met twice with good practice representation at each meeting. At the November meeting, members were provided with an update by Doreen Redwood, the CCG's Mental Health Commissioning Manager, on the 2018 refresh of the CAMS Local Transformation Plan. They're working towards offering more telephone triage to expand the CAMS single point of access and to improve psychiatric liaison services and crisis care to enable children and young people to access more care at home rather than in hospital. Members also received an update on the National Diabetes Prevention Programme, which is being rolled out collaboratively with NHS England with the aim to make 100,000 places available nationally by 2020. And practices were asked for expressions of interest in hosting the programme to be run at their practice. Members received a primary care update from Catherine McDermott and Omid Gillenshaw, which included details on the KMS 1819 specifications, which had been reviewed by the Task and Finish group. The draft 1920 suite of specifications were also being developed, and members were given the opportunity to provide feedback at the Task and Finish group. And finally, Catherine McDermott presented the Connecting for Care software that will be replacing Kingston Care Record, and the rollout of this is planned for 2019. At the December meeting, we had a presentation by Dr. Elizabeth Peregrine, consultant obstetrician and fetal medicine at Kingston Hospital. She gave the council members some service updates and went through recent guideline changes that are going to be made available to clinicians. We welcomed Simon Evans from Connecting for Care, who presented the new system giving GPs access to patients' care notes from a number of areas, such as hospitals and community providers. He gave a demonstration of the software and demonstrated how it will integrate with EMIS, as well as informing us of the rollout plans. There was a number of GP questions and concerns raised in particular relating to where GPs stand medically if we don't act upon or miss any important information from other providers, and we await feedback on this. Omid Gillenshaw gave an update on the KMS specifications, including the new chronic disease service, and he confirmed which of the current KMS specs are for decommissioning and which are for redesign. He confirmed that the new suite of KMS specs will commence in April 2019 with the agreed shorter notice period, and the final suite will we aim to be agreed by end of Feb, early March 2019. The next council members meeting is on the 15th of January 2019. Many thanks.
Any comments or questions for Atin? I'm just wondering about you, as regards the SEND report, whether it might be worthwhile actually bringing a presentation to the council members, just so that we make sure that the membership themselves are aware of the difficulties within the SEND report and the action plans that are coming out of it. So then it's all up to them.
Would you like that in any particular time frame?
I think the sooner the better. Okay, so I think in the next month or two, if the agenda allows.
Sure. Okay.
Thank you. Any other comments or questions?
The only point I was going to say was around the connecting your care and obviously our social prescribing connected Kingston. I think my only worry is about any confusion about what we're connecting. I think it is helpful that we've opted for connected and this is opting for connecting, but I presumably that's a whole South West London piece and that's a done deal. Yeah, oh well, we just have to. Yeah. We did hear about it, we're like, oh gosh. So fortuitously we didn't go for the same adjective.
And then you've got coordinating my care as well. Yeah, excellent. Okay, all right. Atin, thank you very much. Okay, so if we can come to the Integrated Quality Governance Committees in Common across the Kingston Richmond CCG's LDU. Fergus.
Thank you. I'd like to collect my committee, if I may. Thank you, Chair. So this paper is brought to the governing body to ask for discussion and approval of a recommendation that we consider how we work more closely together within the local delivery unit, ensuring that we look at our quality, safety and performance in a better and more coordinated way than we currently do. As you know, we've been looking for opportunities to strengthen partnership but also reduce duplication effort where appropriate, and discussions with the chairs of both the Kingston Integrated Governance Committee and the Richmond Quality, Safety and Performance Committee. There's an awful lot of there are many areas of common ground that we would benefit from actually organising ourselves in a committees in common approach rather than continuing as we have been for the last year. So contained within the paper, there is a copy of the terms of reference, which have been shared with the membership of both of the committees and both of the chairs. And the governing body is asked to consider the recommendation that we form a committees in common approach, and we would call that going forward the Integrated Quality Governance Committee. Happy to take any questions.
Okay, Fergus, thank you. Any comments or questions from board members? David.
It will come up again in relation to the finance one, the next item on the agenda. I find the notion of the phrase committees in common, to put it mildly, confusing. We have committees in common across the southwest of London. Now we're having them in Richmond and Kingston. I don't see the need for that particular reference. Is it constitutionally required for some reason that's escaping me?
Yes. Can I
yes. Thank you, Sarah.
Yeah, sorry, just caught me mid-tea, sorry.
That's all right. Coordinate my cuppa.
So, the reason we call it committees in common is it's because it's a structural governance piece of work. So a committees in common is when the two committees or three committees or four or five or six committees come together, but they are individual committees meeting together, whereas a joint committee is one where it's one committee with representatives from a number of different organisations. And our constitution only allows us to have committees in common because that was the agreement across South West London. So we can't actually constitute joint committees. We can only constitute committees in common. So you can call it something else if you like, but that is just, it just describes the type of committee it is, and it is a kind of constitutional requirement for it to be that type of committee. However, you could call it the Kingston and Richmond Integrated Committee, I think.
I don't want to go there.
Matter.
I think it's enough to raise an arcane point once, not to reinforce it with a second. Thank you.
Okay.
I knew there would be an explanation. Can I, however, make another point of detail, which is that I think it's always important to have limit the numbers of people who have to be there. And I note the terms of reference. I'm assuming at the moment it's going to be 2 GPs from both Kingston and Richmond, or is it going to be one from each, Fergus?
So it should be a minimum of one from each.
So 2 per, for the purposes of the membership of the meeting.
Yeah, we very often have more than 2, sometimes 3 or 4 from the Richmond side, certainly. So I'm really pleased to say we've tried to minimise the number for quoracy, but maximise the engagement.
Well, one way of reducing it by 1 is I always feel sorry for the secondary care doctors when it comes to these committees. Do we have to have the 2 of them because they're neutral in relation to both Kingston and Richmond? Can't you just have 1?
So I have...
Sorry, this is me too much I know about governance. You can, if it's the same person, they can vote on 2 committees, so it's one person on 2 committees. But these are 2 individual committees and they have to be constituted in the same way, and that's why it becomes difficult.
Thank you. I apologise.
Thank you. And I think, the committee itself doesn't often, given by nature of the content, it's not often asked to make a formal decision, if you like. So that's not a frequent occurrence if we can signal in advance. But the secondary care doctors have already asked if they could do turn and turn about to help with, as you say, just with their time commitments and the like. I think we can consider that going forward, certainly.
I think there has to be a change in some of the constitution in the CCG to be able to do that.
My view would be, when you write your terms of reference for your committees, you write that it requires 3 members from the CCG to be present, to be quorate, and then you say, these are the type of people we'd like to be there, but they're not actually required to be quorate, and you just have a minimum amount, and then it gives you a lot more flexibility, and I think that's the way to do it. So it's a bit like the committee in common for South West London. We just say it needs 3 members, one of which must be a clinician, one must be a layman, but one must be an executive. And then we sort it out between ourselves. And only 2 of those need to be present to be quorate. So I would just think a bit more carefully about how you do it to give yourself a bit of flexibility to be able to run the committees.
Okay, Iona.
So I'm aware it's now more than 5 years since public health left the NHS or local public health and went across to the local authority. We have in the past used the Integrated Governance Committee to sort of report our clinical services, bring PGDs, things like that. I know kind of public health isn't referenced here. I don't know if that's a decision that what we might propose going forward, or is it time for us to, stick within the council? I'm not saying we can't do that, but to me, there is a benefit of bringing some of those more clinical services through the Integrated Governance Committee for all sorts of reasons.
I should grovel apologetically and say that was an oversight rather than any intention to exclude.
Thank you. I mean, I know on the Richmond-Wandsworth side, it's quite a different scenario. I don't think they've necessarily participated in quite the same way as we have in Kingston, but it certainly worked for us, and I would welcome keeping that connection.
I would welcome that too, as well. Okay, thank you. Jim.
I support this paper. I think it's a sensible idea. Just a sort of word of generic sort of warning that we're moving into a slightly uncertain future at the moment, both in executive terms, in lay terms, in governance terms, and we should be mindful both of our priorities, of our resources, as we move forward. And there's something called the science of uncertainty, which means basically you don't bury anything too deep if you think you might have to dig it up again. So I suggest we kind of keep flexibility in all these arrangements at the moment, Fergus, because I know we've had difficulty. I think it's a really important committee. I've not been as regular attender as I need to be. Let's not set ourselves up to fail by establishing committees that people are not going to attend because they don't consider them sufficiently important.
All right. Okay, any other comments or questions from board members? Okay, so we're asking to approve the terms of reference given the caveats that we've already discussed. So are we happy to approve this? Yep. Okay, thank you. Thanks, Fergus. So if we can come to the South West London Finance Committees in common, James?
Hopefully this should be reasonably straightforward. So this is really just asking for governing body approval to the terms of reference. These have been signed off by the finance committees in common. They've been through the relevant legal advice. The only thing that we tweaked at the last meeting was around, and again it's back to Sarah's point about giving us a bit of flexibility. If you remember when we first set these up, we wanted a key sort of GP involvement. What we've just said is rather than having a GP from every CCG at every meeting, we'll have a minimum of 3 overall. So that's the major change. And also we've built in a bit of deputisation into the terms of reference. So hopefully it should be relatively straightforward, he says, looking nervously at David. And he's at the meetings, but they're therefore prepared for approval, presented for approval, sorry.
Chairman, no comment. Fine.
Okay, any comments or questions? So just about voting members on the membership, it's got Kingston and Richmond CCG's governing body chairs.
No, that's the previous one, I think.
Ah, right, sorry.
I think you're on the terms of reference for the integrated committee. You want to go to the next one.
Sorry, my bad.
Here you go.
All right.
4C.
Got it. Yep, fine. All right. Any comments or questions around the finance committees in common terms of reference? No? Are we happy to approve? Yep. Okay, approved. Thank you. All right. Safeguarding Children's annual report. Fergus?
Thank you, Chair. So this paper is brought to the governing body to provide assurance to the governing body that the CCG is meeting its statutory obligations with regards to safeguarding children's arrangements. As you know, we're required to make sure that we have functions and considerations for safeguarding not only services that we commission through NHS providers, but also non-NHS organisations as well. And we need to take into account a wide range of statutory and other duties, such as Section 11 of the relevant legislation, our statutory guidance contained within the Working Together, and other overarching NHS standards. So the purpose of this report is to provide the assurance that we are meeting those requirements. And within the main body of the report itself, we take you through the both national and local context for safeguarding children arrangements. Within the requirements we talk about for providers, we've included quite a lengthy update from each of our main providers. And I note within that we've also included quite a bit around how we provide the supervision for staff and named professionals. In terms of our partnership working with the local Safeguarding Children's Board, I'm pleased to say that we do have a very productive and good relationship with our colleagues, and indeed our designated nurse does provide some leadership for some of the subcommittees of the Safeguarding Board. We're compliant with the requirements of the Child Death Overview Panel, but I do just want to mention to the governing body that there are likely changes in the coming 12 months around how those arrangements will be organised across South West London, and I will update in due course through the Quality Governance Committee on how that's progressing. I am pleased to say we don't have any open serious case reviews at the moment. And then further to that, I go through the governance and accountability arrangements that we have within the CCG and talk about within that our systems and procedures, the oversight and our policies and procedures for safeguarding children. There are a number of areas that we've been working on during the time of the report, so some new and emerging areas such as female genital mutilation, but also our prevent anti-radicalisation training that has been a key focus for us. Within the report, I signpost that we have some priorities for the year that we're in now, and I do apologise we're a little bit late with this annual report. We had some scheduling issues with the governing body agenda, but also our designated nurse function. We had some unexpected absence during the course of the year. So I'm pleased to present the report to the governing body, and I'm very happy to take any questions.
Yes, Sarah.
And the answer to this may be there isn't any, but what is the link, if any, to this and the SEND review that we had earlier? Because I noticed there's absolutely no mention of it whatsoever, and it may be that they are just totally separate, but it just doesn't feel right in that respect.
So I think the connections will be much tighter around our children looked after report,
yes, exactly,
rather than the SEND report.
So I looked for it in the looked after children, and there was no mention at all of it.
So there is a more detailed children's look after report to come to the governing body, which will contain quite a bit more around the SEND agenda as well. But unless there are specific safeguarding issues, okay. I wouldn't naturally include it within this report as a subset, because there are many different subsets that we could...
So that's why I was asking, and I suppose the question I was asking really was, do we believe there are any safeguarding issues coming out of the SEND review at all?
Nothing that's been
it wasn't one that they raised as a particular issue. And this annual report was written before, obviously, the inspection. But I think in terms of the action plan, I mean, I guess children looked after is a bullet point within there, isn't it, in terms of about those having the health reviews. So I think we shouldn't lose it, but it certainly wasn't one of the areas they felt was weak.
Yeah, that's why I was saying the answer might be no, but I just wanted to ask the question.
You know, in the meetings that I've attended around the reports with the SEND, it's not been brought up as an issue. Catherine.
Thank you. It was just to sort of pick up on, so page 6, the report where it talks around the technology required so GPs attending case reviews. I it would be nice to have seen that in the priorities in terms of making sure that actually happens. In terms of virtual attendance, because I know that's certainly in my experience that's often evident in terms of people not being able to attend and the importance of that. The other thing for me that I think that I would like to see in the priorities, it's lovely to see so much emphasis on supervision, and that's very close to my heart, but going forward it would be nice to see that as a priority across primary care teams, because that is an area that within general practice doesn't happen consistently at the moment, and it would be really important to see that making a presence within the priorities.
Thank you for both of those points. I guess, so when you asked your question, Sarah, and Iona answered, the one bit that sticks in my head across both is about the responsiveness of primary care around the health assessments. And I think if there is something around the safeguarding side for the SEND report, it's just that, about that connection. And I think I welcome the Chair's suggestion that we raise this profile with the Council of Members, but also with the governing body, because I think that's a key strategy for us. In terms of attendance at case conferences or responsiveness to case conferences, I think there are a couple of issues. I think that the GPs and primary care are not always notified in a timely manner of the requirement to provide a response, and that proves challenging for them. And then that late notification and the request for information by a very short deadline does mean explained that sometimes a technical solution might help the answer to, or help that be part of the answer to that, because it's not always necessary that they're physically present, but that they could dial in. I mean, in terms of technology, a simple telephone call onto a conference call might be helpful. I know this is an area that Dr. Smith, who's unfortunately not with us today, was particularly focused on, and I'd welcome when he's back about his thoughts about how we can strengthen that, because it's been a prevailing, persistent issue for us that year on year we've been saying there's a bit of a challenge around this, but we haven't quite cracked it yet either.
Okay, any other comments or questions around this? Okay, so are the governing body happy to accept this? Yep, and noted. Thank you. Thanks, Fergus. Okay, so if we can come to the health and care plan.
Thank you,
Julia.
Chair. The purpose of the report and the presentation this afternoon is to provide feedback to the governing body on the recent borough event that we held in Kingston as partners with regards to the local health and care plan, and then to make everyone aware of the next steps and the revised timeline for producing a discussion document by the end of March 2019. And of course we will be taking into account the outcomes and the key planks of the 10-year plan. Just to remind members that the CCG has been working across the health and care voluntary sector partnership to produce the local health and care plan. A lot of the initial work's been focused on delivering the case for improvement and gathering insights, and the event that we held on the 21st of November was very much focused on actually gaining further insights and feedback on the emerging priorities from the health and care needs from the Joint Strategic Needs Assessment. And of course this plan is focused across the whole life course of Start Well, Live Well and Age Well, and there are some cross-cutting themes. So in terms of the presentation, if I can take you to that, the first couple of pages talks about the introduction to the event, and as it says on the 21st of November we had a very well attended event whereby we invited local people who were a cross-section of our local population who were specifically recruited to join the event, along with frontline staff and with community stakeholder and other individuals. Within the pack, you've also got an outline for the programme, and it was very much an interactive day, whereby there were lots of tables and lots of discussions working through priorities, understanding the needs of the borough, looking at what people thought were the actions we needed to take or should be taking that would improve the health and care of local people on working in terms of delivering actions for the next 2 years that's going to improve the outcomes for local people. Included in the pack as well, I've reminded everyone that we had what the draft health and care priority areas are, and there's work going on to refine and synthesise those based on some of the feedback. And they, as I said, were drawn up from the Joint Strategic Needs Assessment and the insights from local people, and they build on a lot of the existing strategy work and existing strategies that we have, and so they're included in the pack. I think there are still more work to do in terms of refining those, and that's work we're continuing to take forward, building also on the event. As part of the visuals for the day, and we're going to go to the film in a minute, we had an artist who gathered and did the visual summary, which you will see within your pack. And I think some of the themes that I'd like to pull out from that is the importance for children and young people was around the importance of schools, not only about early intervention, but actually schools and how pivotal schools are in terms of a location, a focal point for the delivery of support, early intervention, information, navigation, and not necessarily, always needing to engage with statutory service, going out statutory services. A call for more information to enable people to support their health, to undertake healthy lifestyles, but also manage their conditions, and actually bringing people together and the information that supported navigation. And then one of the other big themes was around some of the intergenerational activities, particularly around preventing loneliness, which was one of the key themes, and actually very much links into, of course, the national strategy that came out before Christmas. And concepts such as things like time banks were also, so were lots of rich information and energy in the room. What we're going to do now is show the film, which was produced from the day, which is, we'll tell you all about the day. So thank you very much. So hopefully that gave you a flavour of the day, and many of colleagues sitting around this room were there participating in the day along with colleagues from the council. In the pack, we provide some high-level feedback from the participants in the day in terms of how much they valued it, whether they felt their contribution was listened to. And I think what was very positive from the feedback was actually they got very high levels of feeling that people were being listened to and valued the event. The next step, one of the other pieces of feedback was actually whether or not they thought it would make a positive difference to health and care services in the borough. And that's the yellow line that is shown within the bar charts. And as you can see, there is still more work to be done for us to actually demonstrate that actually this is going to make a positive difference and is going to make an impact. And that's where it's very important that all the information that we had on the day is synthesised and pulled together, but also brought together with other valuable pieces of insight work in the creation of the plan in terms of formalising the priorities. And that work is continuing. So in terms of the next steps, slide 11 outlines the principles and the approach that kicked off this whole process in terms of co-design owned across health and care partners and with local people, and is about developing and reflecting the needs of the local population and across the life course, as I've said before, and a strong focus in terms of also supporting some of the South West London work. And we are building on and will continue to build on what we have in terms of existing partnerships, and we're building with it, beginning to build this and check this out and engage on this through existing fora where they are in existence, and set up some other forums to support that. Page 12 really outlines the draft structure of the plan, and I suppose the key important information, other than seeing the valuable piece of work that was undertaken and produced on the 21st of November, is the next steps. As I say, we're in the process of synthesising the information, myself along with Helen from Public Health and with the communications team and a couple of others has got in a room and looked at all the paper outputs from the day, and we've themed that, and as I say, we're joining that with other insights that we've already had about services, because we do not want to lose that valuable insights. We are now in the process where we're looking at how we are going to take all that information and use it to then develop review the priorities and further develop the plans along Start Well, Live Well, Age Well. And we are meeting tomorrow with council colleagues, myself, Tonya and others, Naz, to actually have some discussions about the priorities as well as and how this plan fits in. There will also be a comms and engagement plan that will be supporting this piece of work. So that's probably all I want to say today. The next product will be a discussion document for consideration from March onwards, and that ties in with we'll go to the Health and Wellbeing Board, but also will come out to all governing bodies and other partnership groups for their consultation, for their consideration and views. Recognising that a number of you around the table today were at the event, I don't know if there's anything that Tonya, Naz, Annette want to add in terms of the day and next steps. Thank you. I'm happy to take questions.
Thank you very much. I think the one thing, it's a very short and succinct film, but I don't think it quite captures the energy, the enthusiasm and the buzz that was actually in that room that day. And I really think that it was one of the most positive events we've done publicly in my time anyway. Annette, I don't know.
Yeah, I'd echo that. I think it was the best public engagement event that I've been to. Actually one of the best events, full stop. There was a lot of energy, a lot of positive commitment and input from members of the public. And I've had feedback from patients of mine who were there to say what a great day they thought it was, and how it opened their eyes to what actually is already in Kingston and what is being developed. So that it was a really excellent day, and I think any way in which we can show that even better would be great.
Great. Are there any other comments or questions around the day itself? Okay, so we look forward to reviewing the plan as it becomes more clear. Sorry, Liz.
Yes, it's not a comment specifically related to the day, but just building on what Annette is saying about people becoming aware of just how services are changing and evolving, which is terribly important. I guess the other strand on this is the outpatient work that kicked off in the middle of October. And I guess personally, I'd like to be kept in the picture on that. I'm sure a lot of the population would as well. And that feels another important strand of this story, because I think it's terribly easy for local residents, particularly if they don't use services very often, or even if they do, to kind of assume a picture of services without realising that actually just how much is going on in evolution at the moment.
Okay, fair point. Right, any other comments or questions on the day? So, okay, so I think it was a great day, and I think that we look forward to actually seeing the outcomes of it and how it's actually being taken forward, given the information that we've received from that day as well. So thanks a lot, and I know there's a big team behind actually working through all that data as well. Thank you. Okay, so if we can come to the emergency preparedness and resilience and response.
Thank you, Chair. Just a short report to give the governing body feedback on the outcome of the 2018-19 assurance process with NHS England, which was undertaken in November, and I'm pleased to report that the outcome of that assurance process was substantial for Kingston. There are a couple of minor areas that we've been progressing since we had the assurance visit to tidy up before the end of this financial year, and I, rather than including the 70 or so individual measures that were assessed upon, just highlighted a couple that I think we need to make some progress on. I appreciate we've had discussion earlier about roles for non-executives and lay members, but there is an action within our areas to progress about identifying a governing body non-executive. Now, I think this is more appropriate for the assurance process for level 1 responders, which are acute hospitals, much more so than for us within CCGs, but nonetheless it is one of those areas that's contained within it, and for us to get a green tick we need to identify somebody. So that's something that I'll progress with a discussion with the senior management team about how we might do that. I'm not anticipating that there are any challenges with meeting any of the other actions going forward, so it's just for the governing body to note. One last bit is for me to include the outcome of the assurance process in our annual report, so I'd welcome the governing body's support for that as an approach going forward, so we can make public the assurance that we've had.
Okay, any comments or questions? Fergus? No? Are the governing body happy to receive and note those recommendations? Yep, okay, thank you. Thank you, Fergus. Okay, so if we can come to the board assurance framework. Vicky?
Thank you, Chair. We bring the Corporate Risk Register and the Board Assurance Framework to the governing body twice a year for information. It's actually the Joint Executive Management Team that looks at it in detail on a monthly basis. And in addition, each subcommittee reviews at every meeting the risks pertaining to its agenda. At the moment on the Kingston Risk Register we have 27 risks, 2 of which are very high. One is around the national performance targets, and obviously we've discussed some of that earlier today, and the other one is around potential overperformance in acute services. There's about to be an internal audit across all the CCGs in South West London for risk management, and we'll get the report on that in January. For Kingston, we had some feedback at our audit committee late last year from our auditors that we had improved our processes around risk management. And we've also recently appointed a governance and business officer whose main responsibility is to manage the 4 risk system and to work with the directors on making sure that we manage it properly. So I'm happy to take any questions about the process.
Okay, thank you. As regards the case 16 around the overperformance of the acute, can we downgrade that now?
Shall I take that?
Yes, please.
Yeah, so we can. It's just that it's the timings of the reports. So at the time this report was completed, we hadn't agreed a year-end deal at either Epsom or Kingston, but for next time we can ensure that that comes down.
That's great, thank you. Any other comments or questions about that? All right, Vicky, thank you very much. All right, so if we can come to the minutes from informations and updates from subcommittees. Is there anything else you want to add, Yarlini, on the finance? No? Audit? Oh, he's gone. So Paul was there for audit, but I presume no. Okay, Primary Care Commissioning Committee.
Well, we have had a subsequent meeting, Chair, so just to say, at that meeting we had fairly substantial conversations around the changing KPI specs for KMS for this year, which is going to be a very, very important year for the local contract with GPs, as Atten mentioned before. We talked around the CQC breach notice for Chessington Park surgery and the action plan, which we're working with the surgery on. Talked about primary care at scale pilot activity, and we also looked at procurement of integrated urgent care 111 and out of hours services, which is also a South West London Alliance matter. Thank you.
Great, thank you. And the Health and Wellbeing Board notes or minutes are there as well for review. The recent policies approved, you've got the list of the policies and the links to the website for 424 to 429. And I'm presuming that no one's got any questions or comments around that because they have been approved. It's for information only. Okay, so there's the date of the next meeting is Tuesday, the 5th of March, here at the Fraser Chapel here, between 3 and 5. Are there any other questions from members of the public, Rob? Okay, sorry, Iona.
Right, on one of the finance questions, I did notice in the minutes about the transfer of the residential rehab budget. So I'm happy to see that as a suggestion. The discussion about that with us would be helpful because I think it's said to be coming to the council.
Sorry, can you just explain?
So it's in the finance, one of the finance minutes, I just saw that.
So historical overhang of when we had joint commissioning was that when the borough took on responsibility for the commissioning of substance misuse, for some unknown reason the CCG retained the residential budget, and it just makes sense for it all to become a single budget Iona. So the plan was to transfer the budget over to the council for you to do that because it seems silly us paying for accommodation. It doesn't make when you're paying for the treatment.
So will that be an annual amount that will transfer depending on demand? Yeah. Okay.
Yeah, we'll transfer the budget over. Yes. Yeah.
Annually.
Shall we discuss?
So can we take this out of the meeting? We note there's
a method of doing that.
Yeah.
Right. Yeah.
Okay. Thank you.
Apologies.
So, if I can close the meeting now at 5:18, can we just take a couple of minutes?